So everyone, welcome to Day of Dialogue's fourth session of the day. And thank you for choosing to attend this session today on health equity and COVID-19. My name is Callie Wynn, and I am the Graduate Assistant for On-Campus Events and Civic Literacy at the Center for Civic Engagement. A little bit about CCE. Our mission is to encourage students to take an active role in their communities and to foster broader national and international dialogue. We do that by putting on events like these and others which allow for discussion, but also by encouraging our undergraduate fellows to work closely with some local organizations in Nassau County. If you yourself are an undergraduate student with whom this resonates, please consider applying to one of our fellowship positions, which will be opening for next semester. This particular event could not have been possible without the support of various people in offices. We are particularly grateful to the Provost Office and University Relations for their continued support. And we are indebted to the Executive Director of Hofstra Cultural Center, Kathleen Collins, for all the work she has invested in today's events. Thank you, Kathleen. We are also thankful to the Center's Director, Phil Dalton. And finally, I would like to recognize our CCE fellows who have been instrumental in conceiving of these events, helping market the events, and administering them. We could not have held any of these events without all of the people I've mentioned. Lastly, I'll ask you to note a link I will soon post in the chat. This link will take you to the other events today. After the session, please take a look at that link and join us for further dialogue. Now I'll hand it off to today's moderators, Professor of Writing Studies and Rhetoric, Marianne Trasciatti, and Associate Professor of Counseling and Mental Health Professions, Andrea Nerlich.
Thanks, Callie. It's a delight to be here. The CCE does incredible work, and this is yet another example. Hats off to you all for putting together this terrific day of dialogue, and I'm honored to be co-hosting. Our panel is titled Health Equity and COVID-19, Finding Opportunity in Crisis, and it is part, as I said, of the Day of Dialogue series through the Center for Civic Engagement at Hofstra. My name is Marianne Trasciatti. As Callie mentioned, I am a professor in the Writing Studies and Rhetoric program. Specifically, I teach in the Rhetoric and Public Advocacy program, and I also direct labor studies here at Hofstra. My co-moderator is Andrea Nerlich, who's the Director of Rehabilitation Counseling Programs at Hofstra, and it's been a pleasure to work with Andrea and to get to know her. That's one of the great things about CCE. I'm delighted to see people in the audience who I know and with whom I've collaborated on some projects, activist and academic, as well as people that I don't. And I think you're in for a really interesting session. The session was a topic of importance for us because of our interest in social justice. The COVID-19 pandemic has shone a light on inequities in our society, especially how inequity relates to access for marginalized and vulnerable populations. Many of these struggles are not new, but they've gained attention during the pandemic. They've become more prominent and they can no longer be ignored. However, we don't want to spend our entire time today focusing on the problem. We've got to do this to set context, but what we want to focus on primarily are positive solutions and opportunities that have come out of this crisis. We'd like to talk with you about steps that have been taken to address inequity and the lack of access for communities, and how they can be formalized into our systems. We want to talk about how we can continue to move forward and not slip back into our old ways of operating. To do this, we've assembled an outstanding panel to guide discussion. These three women are at the forefront of the issues we're discussing today, and we welcome their insight and their leadership on these topics. Our first panelist is Dr. Kristie Golden. She is an alumnus of Hofstra, where she earned a Master of Science in Education degree in Rehabilitation Counseling. She went on to earn a doctoral degree in Arts and Sciences with a concentration in Health Administration from Union Institute and University. She's nationally certified as a rehabilitation counselor and licensed in New York State as a mental health counselor. A member of the executive team, she is currently the Associate Director of Operations for Neurosciences at Stony Brook University Hospital, including psychiatry, neurology, neurosurgery, and related areas, and she is an administrative leader for the development of telehealth. Prior to that, Dr. Golden served as Vice President of Northwell's South Oaks Hospital and Broadlawn Manor, where she worked for 21 years and had responsibility for ambulatory healthcare operations, business planning, legislative advocacy, grants, research, and community development. She pioneered the first vocational rehabilitation program at South Oaks, as well as other behavioral health and school transition services. She also serves or has served on a number of legislative appointed committees, including the Suffolk County Heroin and Opiate Epidemic Advisory Board and the Nassau County Prescription Drug Task Force, as well as Criminal Justice Coordinating Council of Suffolk County. Next is Therese Brzezinski, who is also an alumnus of Hofstra. Yay, it's great to have you back, both of you. She is the Director of Planning and Public Policy for the Long Island Center for Independent Living, LICIL, located in Levittown. She oversees the advancement of the organization's disability policy agenda with an emphasis on the development of public policy that promotes and protects full and usable access for people with disabilities. Ms. Brzezinski creates and executes community awareness programming and provides ADA, Americans with Disabilities Act, compliance consultation and training for businesses, community-based organizations, and municipalities. Her areas of interest include disability justice, equity in higher education and career opportunities for students and veterans with disabilities, and inclusive disaster management. She sits on the steering committee for Medicaid Matters New York, the Professional Advisory Board for Rehabilitation Counseling at Hofstra, and the Nassau County Transit Access Advisory Committee, and serves as the lead for the Nassau County Disaster Management Corps Advisory Group. And our third panelist is Ann Flomenhaft. Ms. Flomenhaft was raised and currently resides in Nassau County, actually in my hometown. We're neighbors of Long Beach, New York. She graduated magna cum laude from Manhattanville College, where she became immersed in electoral politics. As a student of politics and history, she developed a deeper understanding of the root causes of oppression and injustice in society, which led her to organize various campaigns. Ann was a delegate for Bernie Sanders' presidential campaigns in 2016 and 2020. In 2016, she was elected to and attended the DNC in Philadelphia, representing Congressional District 4. In 2017, Ms. Flomenhaft helped launch the Nassau County chapter of the Democratic Socialists of America. She's been advocating for single-payer universal health care with Nassau DSA since then. Currently, she's the political coordinator at New American Leaders, which is the only organization that trains pan-ethnic first and second-generation Americans to run for political office and work on campaigns. So thank you again to all our panelists for joining us today. My co-moderator, Andrea, will now take over with the Q&A for the panelists. If at any time any of you in the audience have a question, please put it in the chat and we'll address it at the end of the discussion.
Awesome, thanks, Marianne. And thanks to our fellows, Becca, Gabriella, and Callie, who are in our background and helping us manage all the logistics of this session. It's very helpful to us. And I really want to thank our speakers. I've been excited for this session for quite some time. Myself, I've been doing some work around advocacy and COVID-19 for the disability community, which includes mental health and substance use. But I really think we're really beginning to see so much of the intersectional experience that these individuals are experiencing because of poverty, because of marginalization. So I think the confluence of opinions that we have within the panel is going to be wonderful. As was mentioned, at any point in time, you can put questions into the chat and we'll get to those at the end. Hopefully we're going to time this right. We're going until 2:15 today. So we're going to be mindful both of your time as well as really getting deep into what we're speaking about. For those of you who are attending this session, either for a class or for extra credit for a class, at the end, you have to stay to the end. At the end, we will put a link in for you to submit for your attendance to the event. Those of you that are here seeking continuing education credits for your CRC credential, we'll also have a survey for that at the end that you can submit. Okay, and we'll get those to you. So I'm going to start my questions today focusing at the start of the pandemic. And as we move on, we're going to bring our attention to solutions and the needed actions at our current time. You know, as it is 7-8 months into the pandemic, we've seen a shift where we've gone from, especially in the New York metro area, just heightened crisis and something that we were never used to or prepared for. And now I'm not saying we have a handle on it. We're again still building that cockpit, but we have seen some positives and we want to try to harness on that. So the pandemic affected marginalized and vulnerable populations disparately. So this includes our communities of color, those in poverty, seniors, individuals with disabilities and pre-existing health conditions, and individuals living with mental health and substance use disorders. Our service systems in these populations have been influenced by emergency policy changes in response to COVID, funding and resource shortages, and the other inequities that have really been magnified by the pandemic. So let's start the discussion by taking a look at how the pandemic impacted these communities. So Kristie, I'll start with you. What have you seen across healthcare and service systems for those with mental health conditions and substance use during the pandemic?
Thank you. Thank you for having me as a speaker. I think when the pandemic first hit, there were a lot of mental health and substance use providers delivering services from an outpatient perspective. And most of them had to stop in-person visits and switch immediately to telehealth. And that was done very quickly. People were using whatever platform was available to them in short order, sometimes Zoom, sometimes Teams, sometimes DoxyMe, a bunch of other ones. And, you know, although I guess in the scheme of things that went relatively smoothly, considering how fast providers had to gear up, it didn't work for everyone. So even though telehealth can really democratize access to healthcare on many levels, it's not equal across all communities. So in terms of inequities, I think some of the biggest barriers we saw were there are people who don't have phones. There are people who don't have computers. There are people who don't have access to the internet. So the general perception that it makes it easy for everyone to access doesn't apply everywhere because not everyone can afford those things. Not everyone has those things. And if you add to that, there are challenges with connectivity. So even people who have them, not every community has strong bandwidth, strong broadband capability to be able to connect people. I have a student right now, I have an intern right now who lives in a community who the signal is so poor that I can never really meet with her by video. We have to just talk to each other. So that is limiting. There were older adults that were not all older adults. There are many people who are comfortable with technology, but there were quite a few that we worked with that struggled with getting things set up. And it was difficult to explain to people, especially if there were any types of limitations, how to set things up over the phone. It's difficult. It's difficult for me. I need my 20-year-old kids to show me how to use technology a lot of the time. So, and on top of that, it wasn't necessarily accessible. The platforms weren't always accessible to people with disabilities, visual impairments, hearing impairments. They weren't automatically considered accessible platforms. So I would say that, part of what happened is it left some people without supports. On the flip side, it created tremendous access for some people who might have struggled with other things like transportation and other kinds of issues. So it's a difficult situation to look at and to weigh where are we losing and where are we gaining. And the only other thing I was thinking about with people in the nursing homes, you have individuals who were so accustomed to having the support of their families and people to visit them. And it really impacted their mental health. To not be able to see people and have people come in. The nursing homes certainly weren't set up with a camera and a computer in every single resident's room so that they could have telehealth exchanges with their families. So that's really what I saw on that front.
Thanks, Kristie. Yeah, and I'm sure as we go on with our questions, we're going to see the impact even for those individuals who weren't exhibiting mental health and substance use, that really this has brought about kind of a second wave in terms of the pandemic having a crisis with that. So thank you. And to you, Therese, obviously mental health and substance use are disabilities, and we acknowledge that. But what has the experience of the pandemic been like for the disability community, and really what were their concerns in this early phase?
Sure. Well, and thank you to Hofstra for the opportunity to join y'all today. And I appreciate the fact that Kristie rightfully touched on the digital divide. That's absolutely one of the main factors that right off the bat was a deterrent or a barrier for many folks with disabilities for exactly all the reasons that Kristie so effectively outlined. So in addition to those issues, there's a certain balance of experience that we saw, particularly at the beginning of the pandemic, within the disability community, across disability experiences. And that's really sort of the balance of, yes, the high anxiety, but then at the same time, the ability of people with disabilities to pivot and adapt fairly rapidly. People with disabilities by nature, by experience, and by necessity are folks who have to figure it out every day. So in my experience, very much of what I saw was that kind of energy, even in the face of the crisis and in sitting with all that anxiety, because there was so much unknown in the beginning. And even with that, folks were resilient and were willing to share that with their peers and share it with others, whether it was in supportive phone calls to one another, et cetera. But then in addition to that, and this will come out, I think, again, in sort of the positives that we saw, but I have to say that people with disabilities who have experience in needing to stay home or needing to pivot quickly were willing to share their experiences with the general population of people who don't currently have disabilities, to say, look, I have some experience in this. Don't panic, try this. So that's definitely sort of the overarching contrast, really, that we saw. As far as some very practical things that were issues for folks with disabilities, access to simple things like food, and that was because services like Instacart and Peapod and other grocery service delivery options that people with disabilities often utilize to get their food and other essential needs met. Well, those systems, once the pandemic was here, were simply overtaxed because all of the public were looking to use them. And so that limited access for people with disabilities who on a regular basis had come to depend on those services. In addition to that, the situation for individuals who use home care attendants, many of our folks live in the community, and we're all about home and community-based services, and you'll hear me say that multiple times in our conversation today. Home and community-based services are critical for people with disabilities, and part of that is home care attendants. And the availability of personal care attendants to come into folks' homes at the beginning of the pandemic was very questionable, limited, and really something that brought about fear among a lot of people. Many consumers had concerns about, can I really safely have a PA, personal assistant, come into my house? We don't know anything about about COVID. And so some people chose simply to not have a PA come to them, and they had to figure out other ways to take care of their daily needs at home. Some people made other choices or chose to have folks come in and take a risk. And connected sort of to the personal assistant side of things was the lack of PPE. And even to the current day, personal care attendants for home and community-based services are not considered essential workers. That's something that we're working on in the advocacy community. And so by them not being considered essential workers, often there was not the access to sufficient PPE. So, you know, and then the last that I would really emphasize, and which was probably the most traumatic for people, is really the way that that things were dealt with as far as ventilators and just general medical care in hospitals, and what we've come to refer to as rationing of care. So this is an ongoing issue, but there's a great deal of advocacy around this, and I'll talk a little bit about that when we start to talk about some of the additional work that's being done. But definitely the rationing of care is something that caused a lot of fear and still causes fear and anxiety for people with disabilities, because unfortunately people with disabilities have known, and the crisis has underscored, that oftentimes the lives of people with disabilities are not considered as valuable as those without disabilities, and we need to change that.
Thank you, Therese. That's such a critical point, you know, looking at how, you know, we in our field with disability and counseling view quality of life versus how healthcare sees health-related quality of life and other types of more, I don't know, more numerical odds in terms of calculating quality of life, where it's definitely something that's a subjective experience. So before my dog starts barking, and how did the uninsured and those living in poverty experience this initial wave of the pandemic?
Thanks so much for that question, and thanks so much for having me today, everyone. It feels a big honor to be on this great panel of really talented women. So as Marianne stated, I belong to a political organization in Nassau called Nassau DSA, and we are not service providers. We just work on social, racial, and economic justice issues in the county. So immediately as a response to the pandemic, we established a mutual aid program because people started reaching out to us and asking for help because they couldn't afford to feed their families. So since March of this year, we've provided groceries and other supplies to over 500 families in Nassau and Suffolk. So there's just been a great need for the bare necessities is what we've seen. But the biggest and most kind of impactful, and it has been mentioned by the other two panelists, is this tale of two counties in a way of how the effects of the pandemic really are segregated by race and by class. You know, wealthier and whiter folks aren't facing as many of the obstacles to just surviving as lower income and Black and brown communities are. And I also wanted to just say that this underscores an issue that's been long had in Nassau and across the country. Life was already really hard before the pandemic as it relates to health equity. As part of our healthcare organizing work, we did an in-depth study of over 2,000 New Yorkers that consisted of deep canvassing and asking questions about healthcare access. And this is all pre-pandemic, but just to highlight, you know, there were alarming results for women, transgender people, people of color. Those communities are way more likely to experience barriers to healthcare. And Hispanic respondents were more likely to be uninsured by 26% than non-Hispanic ones. And 70% of the Indigenous folks that were surveyed said they had problems getting the care that they needed. So this issue is longstanding before the pandemic, that there are severe access issues in terms of accessing the healthcare they need because of lack of wealth and lack of access just because where they live and our highly segregated county that we live in. So, you know, it's gotten way worse. The biggest thing post-pandemic has been the loss of health insurance as a result of layoffs. Now more than ever, people are realizing that healthcare should not be tied to your employment because it often compounds all of the issues at once. But yeah, we established our mutual aid program because, you know, food we see is not normally one of our issues that we fight for, but it was a need that really was dire, and there's still an ongoing food shortage. And there's, you know, daily food pantries that are just, you know, constantly busy. So that's really what I saw on the ground of folks in poverty experiencing the initial wave.
Thanks for that. And, you know, you really bring up a good point that I think flowed throughout all three of what you said. These are things that were here. You know, Trey's talking about, you know, PAs, or even if we look at group homes and nursing home care, we're not talking about those day-to-day people are not paid well. So it's not really a hard choice to say, well, you're only paying me minimum wage at best. Why am I going to endanger my life to show up and you're not even providing me PPE? You know, or when we see the segregation and the haves and the have-nots. And but I think that hopefully this will bring these, you know, the pandemic will bring these things to light, and hopefully we can capitalize again a little bit on that silver lining, you know. And right now it seems New York has weathered our first round of the immediate, you know, and we have been moving to reopen and reconvene with services, sometimes in a new way. But obviously we are forecasted to experience a resurgence in the winter, and really any time before we have a widespread vaccine that can be developed and implemented. So now, 8 months into the pandemic, what's been the impact on our region, especially for these populations? You know, we've seen it take a toll on well-being, employment, safety, and resources. So I'll start it off with Therese for this question. You know, what have been the ongoing concerns and inequities as we've gotten kind of deeper into the pandemic, you know, away from that initial wave, and we've, you know, learned some lessons? Sorry, you're on mute, Therese.
Sorry. I think certain aspects we're going to continue to come back to here, and really that here I am with the HCBS sign again. You know, home and community-based services are proving to be, and as disabilities advocates and folks with disabilities across the board have been reporting for decades, home and community-based services are essential, and we can't, institutionalization and nursing homes clearly are not the way to go. This is a message that people with disabilities have been sending again for decades, and COVID-19, if you want to look for a silver lining, if we can call it that, COVID-19 has brought that to bear in such a way that, you know, as you indicated in your opening, that we can't ignore it. So these continuing issues really oftentimes factor around the need to strengthen home and community-based services. There are, I'm glad again, and thank you, Andrea, for mentioning the low pay for folks who do home care work. That was an issue before COVID, and inside COVID, we've seen that exacerbated to a tremendous degree. And so people with disabilities and advocates across New York State and across the country are looking to see that change. And I think, you know, the congregate care risks continue to be of critical concern for our older folks and their families, and for people with disabilities who find themselves in those situations. And this is something that's going to need to be continually addressed across our advocacy. And we need to continue to encourage our legislators to pay attention to this. It's unfortunate that it took a global pandemic to actually shed that light, to get that attention. But hopefully we can keep the attention laser focused there. I wanted to mention too that it's important to think about, because I don't want to although these are critical points, the digital divide is going to continue until legislation changes, so that more folks can have access to tech and broadband, et cetera. So I don't want to take a lot more time with regard to that. But I would underscore that even, as we're now in the latter portion of the pandemic, what we've noticed is that sometimes things that are seen as solutions to help get the country back up and running can actually serve to be barriers for people with disabilities. And we find that sort of in the rush to find these solutions, that isn't considered. And I'll give one very simple, basic example for that. And you can kind of think about some others that may come to mind for you. But very basically, the idea of dining and outdoor dining. And this was a terrific thing as we move further into the pandemic. And it was a way for businesses to reopen and to open, stronger. And that's all wonderful. That's wonderful for our economy. It's wonderful for people's socialization, all of that. What it didn't take into account oftentimes was, what does sidewalk seating mean for accessibility in our streets? So if you have tables stacked on the sidewalks with patrons eating, you're going to find situations where people with disabilities, particularly mobility impairments, can't navigate the sidewalks because there are barriers in their way. So, that's one example, and that's one thing, one aspect that we're working with business owners to take a look at and to take into consideration, so that the solutions that are arrived at for reopening really are also solutions for people with disabilities.
And that's important because we can see how just the natural ableism, it really is pervasive in that case, and how we need to consider more of a disability inclusive, or just inclusive of all, all individuals. Kristie, what about, mental health, substance use? Obviously, the continuation of the pandemic has really taken a toll, but what are we seeing more in that sort of industry?
I think that people were caught off guard initially by the situation, and I think everybody that's probably on this call knows that most people can keep it together for a period of time under significant stress, and that amount of time differs by person. But after a while, people realize this too shall maybe not pass as quickly, so they had to start dealing with it differently. And as the pandemic and the isolation continued, I think it became much harder for a lot of people, even for those who had mild mental health or related types of problems pre-pandemic, because if you think about it, the parents were home with the kids, the homeschooling, the stress increased, the domestic violence increased, people being in a house 24/7 with each other. It exacerbated existing problems and created problems for people that may not have been their primary concerns pre-pandemic. So alcohol use went up, anxiety went up. So what are those things? Those things then demand more resources from the system. So for the people who can access the system, okay, that's maybe fine, well and good. But especially for people who can't access the system, it just makes the disparities even greater, because now you have all of these added stressors and an even more difficult time accessing care. So, you know, we even saw cultural differences. So there were individuals that were concerned about doing things on the telephone or via telehealth because it was a matter of, well, who else is watching? Is it really private? Am I being, you know, targeted? Am I being tracked down? Is someone going to find me that I don't want to find me by doing things this way? So that then exaggerates things even more. You know, in terms of the loss of employment, you had people whose mental health and substance use disorders were exaggerated simply by the loss of employment, because how do you feed your families? How do you plan for the future? What do you do? Even middle-class families that had moderate income that was associated with the same level of debt, you know, paying college loans, car loans, all of these things, all of a sudden they had no income. So the pandemic in and of itself created these additional mental health concerns and substance use disorder concerns that are going to be perpetuated for a while. I mean, everyone is still in the same boat right now in terms of homeschooling for kids on certain days. And it certainly hasn't, 8 months into it, gone away, even though resources have been offered and produced and delivered in different ways. You know, in all the ways that the speakers have been speaking about, and telehealth and the other things, it's an ongoing concern.
Yeah, thanks for that. And, you know, bringing in the employment, you know, obviously being a rehabilitation counselor, you know, I know, and you know, that first of all, the therapeutic value of work for people who are in recovery, living with mental health disorders. But again, and you know, I see in the chat that Kathy DeSalvo, who's one of our administrators over at Access VR, which is state VR services for people with disabilities, that another thing that was really kind of hitting was there was a dichotomy of people who lost their job. Then there was another group of people who they may have been downsized a little, cut back, and so they didn't lose their job and couldn't get the same, you know, public assistance that other people could, but they're just not getting the same level of income they had. And then we're talking about the individuals, especially in these marginalized communities, that all of a sudden were essential workers. And when we think of essential worker, we think the doctor, we think these necessary folks, but we're not talking about the people in supermarkets and other things like that. So yeah, it really posed a risk. And anything you want to add on this question?
Just to hit home your point just really quick, I really thank you for bringing up like grocery store workers and, you know, just places that didn't close in Nassau. Like, it was just shocking to see what business was deemed essential and what wasn't. Like, you know, not to hit on, you know, I love ice cream like everyone else, but like, why was Marvell open, you know, but like other businesses were closed? And it's like, I've heard stories, you know, the Lidl workers or Best Yet workers are being, you know, severely squeezed by, you know, this new conglomerate that's bought out a lot of grocery stores here in Nassau and all over the country. You know what they did for their workers? They gave them PPE a little bit and, you know, a temporary $2 an hour raise. That's nothing. And then I heard a story from a coworker of mine whose mother works in a grocery store. Her supervisor for hazard pay gave her coupons to the same supermarket. That's not hazard pay. So I just think that people are not being taken care of, and it's one thing to, you know, protect and stay at home, but people should be paid regardless of whether they can work or not, because it's not up to them. And people need money to pay for their debt, exactly, and pay to live. So just totally agree with everything that's been said.
Yeah, and another good point made by Kathy that, you know, if individuals were fearful and quit, then that means you don't have access to unemployment. So really, you know, weighing the benefits of if you're talking specifically about individuals who don't have good access to healthcare or have a pre-existing condition, it is a life or death decision to be made. So, I think there's a lot when we think about the negative aspects of this. But if we start thinking about now more so as we're throughout this period of flattening the curve and maybe adapting somewhat in some ways, I love Therese's perspective of people with disabilities have been adapting their whole life, and we're showing you how to do it. So that's a good thing. What have you seen as evidence within our systems to overcome some of these inequities? I think individuals have enacted some flexibility and some resilience, but not necessarily systems that have red tape, systems that have decision making, systems that rely on funding and regulation. What have you seen though as some of the efforts to overcome obstacles to equity within our systems, our emergency response processes, and our day-to-day? So I'll pitch this one first to you, Kristie.
Sorry, I had to unmute. I think, going back, I've been focused on telehealth because it had a big impact on the mental health community. And I think that many mental health providers, and this is a statewide phenomenon, have a typical no-show rate. So there are certain people who don't show up for their appointments for whatever reason. No transportation, can't get there, other problems, some reason they're not showing up. And many providers across New York State had this significant reduction in no-show because of telehealth and because of telephone. I'm not just talking about televideo, but also telephone. So at Stony Brook, our Department of Psychiatry had more than 100% of their normal volume. They had, their no-show rate was 0 for all intents and purposes. And it wasn't unique. That was for clinic providers. That was in every community, even in rural areas. So I think about the value of telehealth and the potential for it to, as I said, sort of democratize healthcare on some level. I think there's huge potential there. It would require some regulatory change, significant infrastructure investments, broadband capabilities, giving out of phones. These are things that can be done. They hold a lot of promise, but they would need a lot of thought around some of these inequities that we've talked about today and how to make sure that we are truly not just making it more accessible for some groups, but for all groups.
And I'm not going to give away the secret yet because, we still have a fourth question, but, yeah, I think that we have to look at some of these, some of these quality responses and as a counselor myself, do I think 100% telehealth all the time is going to be the answer? No. But if we think about access and, how many of us are more attentive? I'm not deluding myself. I don't think 92 people would have shown up to this event if we were on campus today, but we've really just expanded our access and expanded our opportunities for these sorts of things. And anything that you saw in terms of, not just Band-Aid, but we're starting to see a movement in shifts within systems.
Sure. So just really quickly, yeah, I'm not a service provider again, or a medical professional, but just my analysis of this situation is the more investment in universal programs to alleviate gaps in healthcare is the way to go. It's the most efficient and it's the most effective. And I think the only way we're going to make sure that every single person has equal footing in terms of accessing healthcare is through a universal single payer system, because I think there'll always be those gaps, like Kristie said, without broadband for all, without an end to private insurance. I really don't see any type of mass equity on a large scale happening. Just one little stat, referring back to that survey that was done, and I can post a link if folks are interested. It was in coordination with the Campaign for New York Health, but this is pre-COVID. 50% of all privately insured respondents reported skipping or delaying at least one type of care because of cost. So it's just, we're at a tipping point here where we need to be serious and realistic about the gaps in the system are just too big to not take a big universal approach to this issue, because they're all over the place. So that's the only thing I wanted to add.
Yeah, and I know, personally, knowing many people in private practice and many people who are engaged in providing telehealth services, it was a struggle in terms of the private insurance companies getting on board with that, and just realizing that if you're going to have an expectation of continuity of care, that you need to relax, you need to, be adaptive and be flexible to the system. But there were a lot of providers that I know, just because of who they are, that they would take on clients, that they would hope that the situation was going to work out in their favor, because as altruistic as counselors are, it's still their job, but I think that that was definitely an issue for us. Therese, any thought on this section? Or
I think the only thing I would add there is just that this point on flexibility. We've talked about how valuable it is for individuals. As those receiving services, certainly flexibility is essential for those providing services. And I have to say, just I want to take this opportunity to acknowledge that we've seen a great deal of really effective flexibility among service providers. I feel like to a great extent, service providers stepped up and they pivoted quickly, and as you say, in difficult circumstances. And really showed, I think, on a certain level, from the point of view of people with disabilities, including from my point of view as a person with a disability myself, I saw this willingness to listen more closely, and to look at and consider solutions that maybe pre-pandemic we weren't willing to consider. And examples of that certainly are telehealth and the way that all of our work lives have changed. People with disabilities have been advocating for telework as reasonable accommodations, again, for years and years and years. And it took a pandemic to show everybody that, it can be done. And I would just say that as far as systems are concerned, I think the pandemic has shown systems the need for that flexibility that we're talking about. And so advocates for disability justice, for civil rights, find themselves, working triple time to remind leaders that flexibility is essential if we're going to make it.
Andrea, may I just add a couple of thoughts that I had in listening?
Yeah, I saw you come off mute before I pitched it to Ray, so yeah, please.
Just two things, and it's really in regard to Anne and Therese's comments, which are both excellent. One of the biggest problems that we've had historically with telehealth access is actually Medicare, because Medicare only allows for telehealth access for most things in rural communities. New York was not one of the areas, except upstate New York, but in speaking about Long Island, there are geographic restrictions, and Medicare is talking about putting them right back into place in January or subsequent to the public health emergency. So that's a big deal. Most of the commercial reimbursement, most of the commercial insurance companies follow the lead of Medicare. In telehealth, believe it or not, I think some of the Medicare said, okay, no holds bar, everyone can do whatever they need to do for now. But they are actively talking about pulling all of that back, which will have a significant impact on Long Island. And when you talk about individuals with disabilities, especially people who are dual eligibles that are Medicare, that have Medicare and Medicaid coverage, it becomes a problem. So New York State is a little bit ahead of the curve in allowing a lot to take place via Medicaid prior to the public health pandemic. But CMS, our Centers for Medicare and Medicaid Services, and the Medicare coverage, if it gets pulled back to pre-pandemic regulatory oversight, you will not have access to a lot of telehealth services on Long Island. So that is a big deal. It's just something to, you know, to really pay attention to, all of us, in terms of our level of advocacy.
For sure. And I think when, you know, in a sec, we're going to get into a question that really looks at more of this systemic response to it. I just want to open the floor up to my partner, Marianne, to see if there's anything from her perspective and her kind of, you know, realm that she can add to this.
Well, one of the things that keeps popping into my head as I'm listening to everyone raise their particular concerns based on their particular expertise is how interconnected these issues are. So I direct the labor studies program here, and we held a series of forums over the summer about the labor implications of reopening Long Island. And so I think about, you know, when I hear essential industries, of course, I think about, you know, essential workers, I think about doctors, but I do think about grocery store workers, because I've worked with Local 338, which is organizing the grocery store workers and is organizing, you know, cannabis workers for the eventual legalization of recreational marijuana, and et cetera, et cetera. But then I'm thinking about, you know, the disability community and their reliance on another group of essential workers at home health aides, right? And I think, okay, so here we have an instance where the labor movement and the disability rights movement could make common cause. Because if we pay essential workers better, the Raise the Wage campaign actually can be an important sort of adjunct of the disability rights campaign, because if people are making livable wages, then they will work in those industries that we need them to be working in right now. And then I'm thinking about the campaign for gig economy workers when you mentioned Instacart. And I think, okay, if we can get these gig economy workers registered as workers instead of independent contractors, then they can, and we can encourage unionization, or at least coverage under labor law, then we can assure them access to PPE, better wages, and that benefits people that we don't even imagine when we're thinking about these campaigns. So I think, you know, when we're looking at systemic change and the kind of opportunity out of crisis, maybe this is a moment where we need to be thinking about how our movements can overlap and really advocate for things that help. You know, if it helps workers, then it helps people who are in need of rehabilitation services, or people in the disabilities community. So that just keeps reverberating in my head, that there's really, I think, a really important opportunity here to unite our movements and to really advocate across these typical divides. I'm grateful for opening my eyes to the implications of labor organizing beyond just what it will do for workers. We call this in the labor movement social justice organizing, and I think there's a great opportunity here to expand that. So thank you very much.
Yeah, and that's an interesting point. You know, this these hidden outlets for critical consciousness, the idea of, wow, wait a minute, that impacts you. Again, silver lining for me in two ways has been, one, it's really opened my eyes to other areas. You know, some of my wonderful public health colleagues are on here, like Dr. Santella. And, you know, I've really been getting into that literature that, you know, we in rehab talk about psychosocial aspects of disabilities and the way that our society impacts people. Public health people talk about that, but they call it social determinants of health. You know, we are talking about the same thing, but we're using disparate language. And so, you know, just like you said, Marianne, like what you're doing in labor relations, you know, we're looking at in terms of vocational services, but we're just taking it from a different perspective. And then as an educator, my partner, Dr. Jamie Minus, is on here right now. It's really opened up opportunities to critically think of, are we really tooling up our students in a way that's going to make them responsive to the needs of society as they go out? I mean, we've always had a social justice lens, but, you know, the critical skills of telehealth and crisis counseling and just every aspect that you engage in having a trauma-informed lens. I think as students are coming out, the idea of a trauma-informed lens looks at, instead of asking someone, what's the problem? It's more of what brought you here, what got you here, and understanding that there's many things because of intersectionality that the person who's receiving services from you is coming not just for a disability concern, but may have cumulative impacts of trauma. And even if it's more microaggression or less, not thinking about assault or these big levels of trauma, but we're going to see a cumulative trauma that comes out of the pandemic. So we have to be responsive to that. So let's look at longer term solutions. What is it going to take to translate some of these lessons learned into policy and standards of operating that address health, healthcare equity, accessible services? We're not only talking about health now, we're talking about, the health indicator of having a job, because that means access to things. So why don't we start with Anne? First of all, I'd love for you to tell us a little bit about the work that you've been doing around the Healthcare Emergency Guarantee Act and how you can see this as one avenue of a positive response.
Sure. So thanks so much for this question. So I've been talking a lot about the need for single payer universal healthcare. As much as I'd like this to be my own idea, it's actually been a very popular idea. There's a New York State Assemblyman, Richard Godfrey, who popularized the bill in New York as a state level bill, and that's been introduced over 4 times into the state legislature. But there's actually a federal bill as well, what you were referring to, the Healthcare Emergency Guarantee Act, which is co-sponsored by Bernie Sanders in the Senate and Rep. Jayapal in the House. And although it hasn't had much traction, it is the emergency solution to getting everyone free care for the duration of this COVID crisis. And there has not been much action on it. Our group has led several efforts of trying to get the attention of Representative Rice through days of phone calls, just everyone we know calling her office at the same time to get a response. She has been unwilling to kind of even make a statement on the issue thus far. But, we have solutions, and, it's easy to say, hey, this is the solution. It's perfect. Why haven't we done this already? There's a huge reason why we haven't done this already. And there's a huge opponents to this. And so, you frame the question as what lessons have been learned that need to be translated into policy standards. Frankly, I haven't learned any super new lessons that I didn't already know pre-pandemic about the opposition to universal single payer healthcare. But what I'm just always shocked by is just the sheer cowardice of our current political leadership to lead during this global pandemic. We have a super unique opportunity to actually save the lives of over 230,000 people, but guess what? They did nothing. We knew beforehand that our systems weren't capable of handling a global pandemic because of years of disinvestment in healthcare. Just some recent examples that were news earlier this year of Cuomo slashed the budget for hospital beds over the past 5 years. And then there was a huge race to build centers all over the state, temporary hospitals to flatten the curve. Also, Cuomo cut Medicaid in April. So, I just think we're up against these people that have no willingness to get out of the status quo and say no to the special interests of the hospital associations, insurance companies, and big pharma. And just lastly, on the federal level, it's looking even worse. Federal Republicans were buying stock in PPE in January. I don't know if folks know that, but it's just been, and virtual technology like Zoom. So they knew what was going to happen all the way in January, and they did nothing to prepare people who would be most vulnerable and just everyday Americans. So all this to say, all things are really looking to the state level on how we can actually pass single payer universal healthcare. The New York Health Act has been introduced the past 4 years, except for last year, but it's never actually gotten to a vote on the floor. It's really time to just stop asking our legislators and Cuomo for permission for this. Healthcare is a human right, and really the only way that to ensure equality and equity in the health industry is to say no to the profit motive. Until patients are prioritized over profits, we won't have equity in the system.
Yeah, right. Thanks for that. Therese, anything you want to add on that point? Are you working to get off mute, or are you talking? I can't see your mouth.
I think just, and I don't want to pull things off center too much, but I guess I would just take this opportunity now just to say that as far as lessons learned, and one sort of silver lining that I've seen that I really would like to underscore, particularly with regard to the health care community, and the way that healthcare is delivered, and this goes to the way it is funded in future. And that is that with the pandemic, we saw certain movements getting greater traction, and that includes movements like, I'll give an example out of Stanford. The Stanford Medical Access Coalition. I'm not sure if I'm getting their exact name correct there, but their entire focus is to increase participation of people with disabilities in healthcare and in the delivery of healthcare as MDs, as nurses, as other supportive healthcare professionals. And they are doing tremendous work at Stanford, in particular Stanford Medical, to look at equity, disability equity, and in particular during COVID. And I think COVID has, again, shown another light on the fact that movements like that and initiatives like that to encourage bringing the disability perspective directly to medicine and to the folks who are providing the care and increasing awareness in that way is valuable beyond measure. And it's my hope that we'll see medical schools like Hofstra Medical and Stony Brook as well to take on those kinds of initiatives, and really to, again, want to encourage people with disabilities, recruit people with disabilities for medical school and nursing school and healthcare positions, because in order to, in this, what's going to be our post-COVID world, which is going to be the cause of new and renewed disabilities because of its effects for long haulers and everyone else. That perspective, the disability perspective directly infused into medical care must be included, and not just on the fringes. And I think that's what SMAC at Stanford is showing. They've done a tremendous job. I'd encourage you to take a look at their website and what they have been doing. But that really stands out for me, that we need to see a shift in healthcare and medicine, and a shift that really brings to the forefront disability experience and problem solving that you can't get anywhere else but from folks who live it every day.
Therese, you stole a thought out of my brain. One thing that we've been talking about is this idea of the long haulers. Is this idea that I presented last week, and obviously two things that are dear to me. It's like the only two things that are probably inevitable in your life. You're going to work, and at some point, if you live long enough, you'll have a disability. So understanding disability is important, but I would throw the challenge even further. And I know, like I said, I have a couple of my colleagues on this call, throwing the gauntlet not only to medical school and the frontline workers, because I think that's tremendous. A representation there is tremendous. But it actually may have less of an impact, because it's going to be that one medical professional serving their patients well. But if we look at those who are being recruited into health administration, if we look at those who are being recruited into public health programs,
Absolutely.
to really affect at higher levels, and really try to bring this mindset of disability inclusion and anti-ableism to a higher level, you know, because yeah, we can all be, as a counselor, I can be really great and empathic and disability inclusive to my, you know, to my consumers and clients, but if we don't overhaul the field, that's the bigger obstacle. And Kristie, what are your thoughts, I mean, on that, or just kind of what you're seeing as lessons learned and how we need to integrate it?
Well, I think, you know, what you're talking about is very important in the fact that I think it was Therese who said before about curb cuts and tables on curbs and people being able to go through, and just using that as an example. I think that's a clear example of how globally we don't always think about these things. I'm super heightened awareness to working with individuals with all different types of disabilities, and I didn't even think of that there's tables on these sidewalks and people can't get through. So if I didn't think about it, you could just imagine how many other people didn't think about it. So how do we get past that? You know, I think lessons learned from my standpoint, you know, we need to think about how do we prepare our communities for this universal connectivity, whether it's by phone or by, you know, how do we keep people connected without running into problems? You remember in the beginning, there was just too much activity on the internet. People's things didn't work. We talked about the inequities before. People don't have access to a phone or don't have the ability to do these kinds of things. How do we get companies like Verizon and other organizations to make sure that our communities have access? How do we make sure that the payers pay for things regardless of what it is that's you know, what method is being used to obtain services? And I'm thinking about from the mental health side. You know, I think work from home considerations are important. That for those people who can work from home, what I'm seeing now is a little bit of, it's really two ends of the spectrum. You have some employers that are saying, wow, this is great. We don't have to lay out money for rent. We don't have to have office space now. This is wonderful. Let's let people work from home, which on many levels is great because that money could perhaps then be reinvested in the employees in those companies, right? But you also have the flip side. You have a lot of people saying, oh my goodness, I can't wait to get back to the status quo. Let's get everybody back on site. Let's get everybody back into the way things used to be. And I think from my standpoint, that's a problem. We don't have to always do what's always been done. We have to think about what's right for the individual. If we can't have a work-life balance, and for some people that might mean working from home if they can. For other people that might mean, oh my God, get me out of my home and get me someplace else for a period of time. So, you know, it has to be individualized on some level. So I think employers need to have that forethought. And you'd be surprised at what can actually take place remotely. And speaking from a healthcare perspective, one of the directors that reports to me was struggling with an employee who was saying she didn't want to come back to the office. She wanted to maintain working remotely. And he was saying, why? You know, you can't do that work from home. You have to be here in order to do that work. So I'm sharing this story because I think it helps to put things into perspective. He came to me because I'm his supervisor and we talked it through. And I said, why don't you look back at her work in January and figure out what did she do in January that she could do from home and what did she do that she couldn't do from home, because that was pre-pandemic. And after looking at her caseload and looking at the work she did and really trying to make an honest assessment, he said, you know what, 25% of what she does, she can do from home. So he had this realization that he was just stuck in this old way of thinking that he was able to overcome by actually looking at it, taking the time to look at it. So I think every single one of us needs to do that in our own ways, to look at our own situations and say, what's realistic for us? And then employers need to do the same thing. They have to think of what is truly realistic. Having someone in an office doesn't necessarily mean they're more productive. In fact, I think I'm sometimes more productive at home. So those things are important. I think PPE, you know, people talked a little bit about personal protective equipment. the state government, and some people may not realize this, were directing where PPE went on some level, not in all cases, but in many. And that is, that piece is a little unknown to people, that if something was coming to be delivered to you that was entitled PPE, it might get diverted. But if it was entitled nightgowns or something else, then it might not get diverted. So this is what goes on. And that there was a shortage of PPE across the nation. It wasn't, let's make sure these people have a lot and these people don't have any. It was just a general shortage. So how do we get ahead of that the next time? How do we prepare better for that so that we don't have that shortage? And I don't know what the answer to that is, because, it's not a simple thing. And last point that I want to make is, some of you may be familiar with the Medicaid redesign work that was initiated under the DSRIP program, the delivery system reform that's taken place over the last 7 or 8 years in New York. And that really looked at, how do we make a better healthcare system? That was part of the waivers that were under the Affordable Care Act. How do we make a better healthcare system that reduces these inequities, that reduces disparities in different aspects of care? And I just learned today that New York State is initiating a new committee, because the DSRIP initiative sort of it ended in its formality, even though people continue to work on projects. They formed a new committee statewide to look at how to reduce healthcare costs so that they can make sure people are able to access things in an equal way. I just heard about this committee today, so I'm happy to hear that New York State is still continuing to target this and focus on it. Part of the DSRIP initiative was health literacy, and that's key with the pandemic. There were hotspots in communities where communication was either English was not the first primary language. There were other things that needed to be taken into consideration in terms of helping people understand what it meant to be in a pandemic and what social distancing means. And that health literacy is very important. So in planning for the next pandemic, we have to think about how to make sure that we approach our communications in a very diverse and with a focus on health literacy.
And I think that that's an important piece, because and not only thinking about linguistic differences with health literacy, but cognitive understanding. How are we reaching out to the intellectual and developmental disability, or those with traumatic brain injury, or maybe those with dementia? How, the simple things of, we did a good job in New York State about, having ASL interpretation for public service, in press conferences, but we weren't seeing that at the national level, so I think that really thinking about this and being proactive, just aside from what we're saying about the long haul, I think we have to, think about that. Therese, do you want to add something to that?
Oh, I just wanted to note that, yeah, you're absolutely correct that on the national level, as far as providing ASL interpretation, we've seen nothing. But I would like to note, to give you a little bit of the taste of this in New York, and for New York and New Yorkers who are deaf and hard of hearing. I don't know if y'all remember, but for Governor Cuomo's daily briefings, for the greater part of the first part of the pandemic, the initial part, Governor Cuomo had no ASL interpreter. And then later you saw it happen, and that happened as a result of direct advocacy here in the state of New York to actually take an action against the governor's office to force them to provide ASL. So I just wanted to make sure and give that shout out to my fellow advocates for ASL. It was important work that they did for New Yorkers.
Yeah, and the other side of that, when we talk to our friends at the Commission for the Blind in New York, the idea of what's the solution? Everyone will just go into Zoom or Teams or whatever we have. they're not accessible platforms for those who are blind or visually impaired. And so just again, considering the ableism that, you know, in our quick fixes, thinking about the ways that some of these things, but again, as I mentioned, being proactive, and please add questions to the, you know, if you have them. I love the comments that have been coming through. They've been excellent. But, you know, the idea of being proactive, you know, we talk about long haul, we talk about likely respiratory, cardiac, cognitive, physical, and health disabilities that are going to be secondary to having experienced COVID. We also, just those of us who are working from home, I don't know who else's back is killing them. I don't know who else's neck or vision is starting to wane. And then, you know, we have mentioned the isolation. So the isolation for some people is good, for other people may have put them in dangerous situations in terms of sexual or physical abuse, and having them isolated with their abuser. And just the other aspects, you know, and my colleague Jamie, who's on this call, you know, this is exacerbated or really brought about things like tech addiction, you know, and, you know, as much as we want to be great parents and say, oh, we, you know, stay off your screen. Well, I don't know, it's the only way my son's socializing right now. So we have to be mindful of these other things. And Jamie, I don't know if you want to add anything to what you've seen at this time.
I mean, there's a few research articles that have come out of China, I believe it is, that has looked at COVID and the impact on tech addiction. I mean, not a lot of research is out there now, but it is a definite concern, and it's quite extensive in terms of the level of usage, and to the level it's increased with gaming and the use of social media. So efforts are being put forward to implement more treatments, even exclusively having clinics dedicated solely to that issue, especially in this day and age with COVID-19 going on. So, but I wanted to point out one other leveling of this. I'm not sure quite how it ties in addition to that issue, talking about the long haulers that was brought up earlier. You know, in the world of rehab, we also deal with like employment. And so the other angle of this is how these individuals are going to get back to work again, and all the implications of unemployment long haul based on inability to be able to get back to full time, and what impacts this might have on Social Security, disability income, and such. And so I think we were talking a little bit earlier about the importance of universal thinking to try and shift systems, but I think we also need to be considering the employment realm as well, and how we're going to really tap into employers to shift their thinking about how to work with people who have had COVID and are trying to get their way back into employment again. Especially, this is our 100th anniversary of the Americans with Disabilities Act, and this will be a new category that will fall within that law. So
State VR.
Yeah. Absolutely.
So you said 100 years for, it's 30 years for ADA.
I'm sorry, 30 years for ADA, sorry, 100 years for state VR. Yes, thank you, Andrea. So, you know, again, it's just a whole other layering to these issues of inequity that we need to be thinking about as well. And we know employment means wage means ability to purchase and be a member of society. So I just wanted to tailor that into the conversation as well.
Yeah, I think, you know, it's been nice for me to obviously my foray into a lot of this more health equity, which is more of a public health issue, has been newer, but this has really enlightened me, as I mentioned before, to look at the intersectionality and really look at how we can gain some traction and maybe use different movements and different aspects of society, both from public health, health administration, labor relations, you know, activists and advocacies on the political realm, to hopefully further the agenda of understanding that these marginalized communities really need some assistance. And hopefully, like I said, I think we've done, especially in disability, we've done some wonderful things in terms of emergency preparedness post Katrina. But that emergency preparedness was for like the 2 or 3 weeks after a hurricane, not for the 6, 7, 8 months to 2 years following a global pandemic. So I think for all individuals that we work with across our service settings and across our specialty fields, you know, that we do have a long way to go. And, you know, I think that we need to be proactive within our fields to see how we can further those things. So I want to thank you. I mean, obviously, this is important. And as I was secretly told, this was the largest attended event so far today. So I'm very happy for that. I'm very happy for your interest. So many wonderful perspectives were shared, and I thank you. I thank our panelists wholeheartedly. As Callie put in, if you are a current student, you can click on the link to verify your attendance for class. If you're in Dr. Santella's class, he said all 23 of you were here. But if you were doing this for class attendance, you can click on that link. And if you are a rehabilitation counselor, you can click on that link, and I will soon in the upcoming week send you a certificate for that. Okay, so I want to thank you on behalf of our fellows of CCE and of Marianne and myself and our panelists for attending today. Thank you so much.